So I think we can start. So we will need some volunteers from the final year students who can come forward and answer the questions which the two experts, Dr. Peush Sahni, I'm sure all of you know, but he's the chief of GI surgery at AIIMS New Delhi, and my former colleague, Dr. Behari, who is a professor of surgical gastroenterology at SGPGI, Lucknow, both very senior and highly experienced persons as far as surgery for portal hypertension is concerned. So I think one of the students has to come forward and start saying that what are the indications for surgery in portal. Any final year student?
Good morning, sir.
Yes.
Myself, Lokesh, I'm from AIIMS New Delhi, sir, final year resident. The indications for surgery in portal hypertension, in non-serotic portal hypertension, can be grouped under emergency and elective setting. In the emergency setting, the indications are bleed that is refractory to medical and endoscopic management. In the elective setting, the indications are symptomatic hypersplenism, portal biliopathy, growth retardation in children, and also as a primary prophylaxis in patients with EHPVO who stay away from tertiary care facilities or who have a rare blood group in whom a major bleed will be difficult to manage.
So, Dr. Piyush, this question is almost always asked from students in the exam, that what is the role and place of prophylactic shunt surgery in patients with portal hypertension? I know that your group has been the most strong supporter of prophylactic surgery. Can you please tell students what they should say when they are asked in the exam and what they should practice when they become consultants?
So if I'm the examiner, the answer is straightforward. There is an indication for prophylactic surgery in patients with extrahepatic portal venous obstruction. And essentially, this should be done in patients who have high-grade varices. So patients who have grade 3, grade 4 varices and don't have any of the other indications that Lokesh has just mentioned. So those would be classified as portal hypertension, surgery being done for prophylaxis. If there is any other indication, so we are not talking about just prophylaxis from bleeding, but from any of the other indications that are standard indications, that are accepted indications. So anybody who has never had a bleed, who doesn't have symptomatic hypersplenism, who doesn't have any of the other indications that Lokesh mentioned, then those people would be classified as prophylactic. Now, why do we support prophylactic surgery? The evidence is that at least whatever evidence is available, some are anecdotal evidences and some are data which is based on prospective or retrospective case series. And these are not alone from India alone, these are from various countries all over the world. There's some data from Mexico, there's some data from France, there's some data from Italy. And in all these places, the evidence seems to be that what we may consider an innocuous thing is not innocuous. That means the first bleed itself could result in mortality. It may not be to the same proportion as in a patient with advanced cirrhosis. Even in non-serotic portal hypertension,
don't tell these things. I have done all these things. I have done 1 or 2 is not missing. You tell after 2 which is missing, that alone you tell. This and all.
Okay, I'll continue. I think.
I have settled all these things in the phone.
So all this data suggests that it's not the first bleed may not be an innocuous bleed. It could actually result in mortality. Number one. Number two, if a person is living from a center or living far from a center which can manage a massive GI bleed, a massive variceal bleed, then this likelihood of mortality from the first bleed tends to increase. And there doesn't seem to be any adverse event or an adverse effect of doing a prophylactic shunt in patients with extrahepatic portal venous obstruction. While in patients with non-serotic portal fibrosis, I'm not saying non-serotic portal hypertension, non-serotic portal fibrosis, there does seem to be some adverse effect of doing a shunt. Hence, we don't advocate doing a prophylactic shunt in patients with non-serotic portal fibrosis. But in patients with extrahepatic portal venous obstruction, we definitely advocate doing it. Now, if I am not the examiner, then there are people who do not believe that this should be done. So if you are going to say that you would advocate doing a prophylactic shunt in these patients, must be very clear. High risk varices, that means grade 3-4 varices. A person who doesn't necessarily have good access to a tertiary care facility. So somebody may have access to a tertiary care facility 200 kilometers from his place of residence. However, for that patient to get to that hospital 200 kilometers, it could be an issue. And access is important. You could also be living in an area where blood transfusion facilities are not available or may not be available in adequate amounts. Or he starts bleeding and the person who is in and around that area doesn't know of any other method except for an endoscopic method of controlling the GI bleed. And therefore, if the facility for getting to the endoscopic center is also limited, again, distance, bad roads, rural area, etc., you would need to tell these patients to have a prophylactic shunt. Now, having said this, if I'm not the examiner, you will need to give some evidence of why this is so. So one is a paper that we've published already and shared the data with all of you in relation to the outcome following prophylactic shunt surgery in patients with extrahepatic portal venous obstruction. We've also published a paper on prophylactic shunt surgery in patients with non-serotic portal fibrosis, and that tells us that it's not a great idea to have this done. This data you should be aware of and be able to argue using this data that you support prophylactic shunt surgery. On the other hand, if you don't wish to support that concept, or you are definitely, you're aware of the fact that the examiner who is asking you questions is not inclined towards doing a prophylactic shunt surgery, then you need to be aware of the data which people believe does not support prophylactic shunt surgery. Primarily, the mortality and the rebleed rates following a prophylactic shunt. So mortality, morbidity, and rebleed rates are what are, if those are high after doing a prophylactic shunt, if encephalopathy is something that somebody has recorded, then that could be an argument against. We have recently looked at minimal hepatic encephalopathy in patients, not in a very large number, but in a small number. And we found a reasonable incidence, the same as we published before. At that time, we didn't call it minimal hepatic encephalopathy. We called it subclinical encephalopathy. And we hadn't used all the tests that are currently advocated for minimal hepatic encephalopathy. We'd done a few less. And therefore, that rate was a little lower. But the same patients who had been defined to have subclinical encephalopathy, this is a paper published in the British Journal of Surgery. I think it was in the early 90s or late 80s. I don't remember the exact reference, but it's published in British Journal of Surgery with Professor Mahapatra from Bhuwanesh being the first author. He'd done the study while he was training with us at that time. And that data suggests that nothing happens to these patients. They have a low incidence of subclinical encephalopathy if you measure their ammonia levels, if you do their brainstem artery evoke responses, if you do a number connection test, ask them to do reverse counting, you will find a little abnormality in these patients, and they would be classified as subclinical oblique minimal hepatic encephalopathy. But over a follow-up period, a long follow-up period, we've not noticed encephalopathy in these patients. Now, the numbers are not that great, so we haven't looked at 1,000 patients. We looked at a small number of patients. And therefore, what you need to be also aware of is that somebody could argue, if you use this data to say that we can do prophylactic shunts because encephalopathy does not happen. Clinical encephalopathy does not happen. We've seen 2 patients with clinical encephalopathy in patients with extrahepatic portal venous obstruction. In both instances, we had the hepatitis B virus in these patients, and that was probably transfusion related, and the acquiring of the hepatitis B. And this happened many years ago, and there wasn't treatment available at that point in time, and these patients progressed over a long period of time to develop encephalopathy. On investigation, they were found to have some evidence of cirrhosis, and therefore these patients probably did develop encephalopathy, but related to another additional cause rather than the shunt itself. I hope that helps.
May I make a few comments?
Anu, just 1 minute. So please take note that Dr. Peush Sahni used 2 terms, non-serotic portal hypertension and non-serotic portal fibrosis. They are not synonyms. Non-serotic portal hypertension includes EHPVO, NCPF, and some people would say even post-hepatic like Behari. So please be clear about these 2 terms. Yes, Dr. Anu, please.
Sir, I just wanted to make a couple of comments that about primary prophylaxis. One thing is probably because we really don't get these patients. Most of the patients that we get are the ones who are referred to us, and they've already undergone endoscopic procedures. Very rarely it happens that a patient comes in the OPD with a huge spleen, found to have EHPVO, and who has not bled. So that is one thing. The thing is that many a times these patients have an indication for splenectomy in the form of, say, a painful splenomegaly or symptomatic hypersplenism, and the patients have eradicated varices on endoscopy, have no biliopathy, no other indications, and then one wonders whether one should do a splenectomy, and in that case the shunt becomes prophylactic. It is not primary prophylaxis. The main indication was for the removal of spleen, and then one doesn't want to lose the opportunity because the splenic vein is going to thrombose, and the shunt still remains prophylactic. So many a times, I would say that the large group that we see, it's hardly for primary prophylaxis. And then I think the endoscopists would probably argue, and therefore I think Dr. Peush's point that if I am the examiner, you can say primary prophylaxis. But otherwise, it will be like high-grade varices or ectopic varices or PCC and a symptomatic splenomegaly. Another point I just wanted to say, somebody said emergency, this thing is for bleeding. In today's day and era, I feel that these instances should be and are actually rare, where you would be doing a shunt in the emergency setting. Ideally, either we kind of make it into a semi-elective setting and tide over, but in the middle of the night, I would say luckily these instances are very rare, and most of the time it would be an elective thing.
Yeah. So the benefit of presence of Dr. Vivek Saraswat with me. He was earlier the head of the Department of Gastroenterology at SDMH, recently joined us. I would like to ask Dr. what are these high-risk varices? Because Dr. Peush Sahni used that term. So I would request him to elaborate on that. And second, the point which Dr. Anu made, that today the control of acute variceal bleeding is by and large non-surgical. So these two issues I would request Dr. Saraswat to tell you about.
Good morning, everyone. Good morning, Anu. Good morning, Piyush. How are both of you? Thanks,
Morning, sir.
Vinay, for the
All
question.
good, all good. Thank you.
Good, good, good. Right. So high-risk varices in the context of the esophagus, you look at the size, the red color sign. The size is generally grade 3 to grade 4, which would mean that it occupies some circumference of the esophagus from the line as well as on the surface. And then the red color sign can be hematocystic spots, red spots, and red wale markings, which are often called varices on varices. And finally, there will be nipple presentations or adherent clots, which will be signs of recent hemorrhage from varices. So, according to the Baveno classification, which we follow for portal hypertension, all these are predictors of the risk of rebleeding. And the North Italian Endoscopy Club, way back when they were looking at primary prophylaxis of with beta blockers in cirrhotic portal hypertension, had devised a predicting scale by which, looking at the child's grade, looking at the size of the varices and the red color sign, you could predict a bleeding risk from somewhere between 30% for small varices in compensated cirrhosis without red color sign to about 85-90% in child C, large varices, prominent red color sign. Similarly, high-risk signs have also been described for gastric varices. The risk of bleeding from gastric varices is relatively less than from esophageal, but presence of red color sign as well as punctate elevated lesions and stigmata of recent hemorrhage on gastric varices would make it high-risk gastric varices. The other point was that, yes, I think with the advent of endoscopic techniques for hemostasis, earlier it used to be sclerotherapy, now it is variceal ligation, or rarely a combination of the two for esophageal varices, as well as glue injection, either freehand or endoscopic ultrasound guided for large gastric varices. The predominant modality for control of acute bleeding remains endoscopic. And in those situations where endoscopic is not working, you resort to mechanical means like a Sengstaken Blakemore tube, Minnesota tube, or now you have these SXLR expandable metal stents, which apply tamponade to the varices and retain the esophageal lumen and allow you to continue to feed and monitor the patient for a period of up to a week till the next step is sorted out. And finally, intervention radiologic techniques, which allow you to, in those situations where temporary hemostasis has been achieved, but the risk of rebleeding on deflating a balloon or removing the stent is high, then the intervention radiology techniques of TIPS or a BRTO may be resorted to even in EHPVO, and particularly in those who have good liver function. These would be modalities. So that is the present practice. So that one needs to bear in mind.
Thank you, Dr. Sara. So I'll go back to Dr. Piyush and Dr. Anu again. That suppose, as Dr. Anu mentioned, that the indication for surgery is only splenomegaly and hypersplenism, and the patient either has not bled or has low grade or no varices, or the varices have been eradicated. Would you do a splenectomy alone without doing a shunt in these patients? Anu first.
Sir, till now we have been doing the shunts in these patients. As I said, we don't want to lose the vein, and because now we feel that yes, bleeding is in most of the patients controlled by endoscopic means, but the other long-term associations which are there in the form of portal cavernous angiopathy or say bleeding from ectopic varices. After endoscopic eradication also, patient may develop, like after the eradication of esophageal varices, patient may develop gastric varices. So we have been adding a shunt whenever we have done a splenectomy. of late, I think, you know, every surgeon's recent experience always colors their perceptions. So we have had a few children who have gone on to develop nephropathy, and they presented with generalized edema and asarca, proteinuria. And we have had very recently, like 3-4 patients who have developed this. And I'm wondering whether some patients with EHPVO also behave like
Gastro University
in non-serotic portal fibrosis. So I don't think I have a complete answer. Till now, we are adding shunts. We are adding shunts in a patient who has already bled, especially from gastric varices, and a patient who has PCC and other softer indications like growth retardation, and we have been adding a shunt.
Dr. Peush?
Sir, we would definitely add a shunt. We anyway believe in a prophylactic shunt, so it makes no sense for us to do a splenectomy alone. If for some reason what we thought was the splenic vein, and if for some reason when we go in and find that either the splenic vein, what we thought was the splenic vein on a Doppler ultrasound, is actually a collateral, there isn't a splenic vein, or if there is an injury to the splenic vein while being dissected, then in that situation, we would, instead of doing a shunt, we would add a devascularization. We would definitely not do a splenectomy alone. We would do a splenectomy with preferably a shunt, but if for some reason it can't be done, then it would be a devascularization.
Piyush, regarding your the issue of prophylactic shunt, a couple of points that I thought I'd request your clarification. The study you quoted in which you have done look for a minimal encephalopathy with psychometric stent tests. Did you do a baseline study before the shunt and then repeat the psychometry after the shunt, and did you find deterioration? Because there are literature data and also from about 20 to 30% of patients with EHPVO, with NCPH basically, had evidence of minimal encephalopathy even before a shunt was done or offered. So that was one point. And the other was when you say prophylactic shunting, you're looking at prophylaxis for bleeding, I presume. How about prophylaxis of portal cavernoma cholangiopathy? So that, I mean, have you looked at your data to show what is the long-term follow-up of shunted patients and the prevalence of portal cavernoma cholangiopathy in this subset? I thought treatment of portal hypertension is most crucial for preventing this relatively uncommon, but then a very difficult long-term complication that might arise.
So thank you, sir, for those questions.
Before you start, I would like to request you to kind of give a brief overview of portal cavernomatous cholangiopathy to the students. What is the entity, and then address the shunt, because this is a frequent question which is asked, and I have found that some of the students are not clear about it.
Sir, I'll answer the first question that Professor Saraswat posed. Have we done the studies before and after? Yes, we have, before and after. The paper in the British Journal of Surgery documents the before and after. Recently, the study that we've done, we haven't published it. We've just presented as an abstract in one of the conferences. And there too, we did before and after. Yes, the rates are in the range of 16 to 20% in the studies that we've done. Previously, in the 80s, late 80s, early 90s, and more recently last year, actually 2019. It started in 2019. We wanted to do a certain number, but because of the pandemic, we were not able to achieve those numbers. And we decided that we would, postpone the study till a later date when we were able to reach those numbers again. So that's with that out of the way. Personally, I prefer to call the condition portal biliopathy rather than portal cavernoma cholangiopathy. I understand that that's the term that's been suggested by the INASL, the Indian Association of Study of the Liver. But my basic problem with that term is that that term makes it clear that it's the cholangiopathy happens only if you have a portal cavernoma. while the numbers are small, portal biliopathy does occur in patients with non-serotic portal fibrosis, as well as in patients with cirrhosis. So therefore, the portal biliopathy that is seen in all three conditions, extrahepatic portal venous obstruction, non-serotic portal fibrosis, and cirrhosis, in all other aspects is the same, except with the frequency with which it occurs. And therefore, to call portal biliopathy in patients with EHPVO portal cavernoma cholangiopathy and portal biliopathy in NCPF and cirrhosis does not make sense, because a lot of the patients who have NCPF and who have cirrhosis and have portal biliopathy have no portal cavernoma. So that's one. The condition per se is a condition which, in the presence of portal hypertension, affects the biliary tree. There are two hypotheses. One is that it's a direct compression effect of the varices on the extrahepatic biliary tree, and this results in an abnormal biochemistry by way of raised GGT alkaline phosphatase, and later on, over a period of time, it tends to cause clinical evidence of jaundice, and then all the manifestations associated with obstructive jaundice, including cholangitis and severe cholangitis, severe enough for them to require emergency endoscopic measures to try and control the cholangitis. The other hypothesis is that it's actually an inflammatory process. It's not just a simple compression on the varices itself, but also an inflammatory process which, because of which the strictures that form tend to be more permanent, and just decompressing these doesn't necessarily lead to complete relief of symptoms. We see a certain proportion of patients who undergo shunts, that means portal decompressive surgery. So if this procedure is being done and the shunt remains patent and the portal pressure normalizes, then ideally, if it was if this condition was caused by the high pressure and direct compression on the varices alone, then almost all patients should respond to this treatment. Unfortunately, that's not the case. That doesn't happen, and therefore we need to explain this by another hypothesis, and that's the second hypothesis. So that's portal biliopathy for you. There is some evidence that patients who have portal hypertension lasting for a long duration tend to develop portal biliopathy more frequently than people who've had portal hypertension for a shorter duration. So the duration of the illness tends to affect the occurrence of portal biliopathy, one. Second, I was going to say something and I've forgotten it. Anyway, when it comes back, I'll have to tell you.
Anu, what you would like to add?
So, hello, sir. Just a comment. I agree with Dr. Sahni in the fact that it is not a direct correlation in the sense that just achieving portal decompression means that the biliopathy will be taken care of is not true. There are other factors involved, maybe inflammation, maybe ischemic strictures, long-standing ischemic strictures, where there are changes in the biliary wall, which are not going to reverse on just portal decompression. In fact, not only not reverse, but many a times, in fact, whenever we have gone in to tackle persistent biliopathy, even when the shunt is patent, even when the portal pressures are lower, access to the biliary system may still remain difficult. And this now I have seen often enough that I can say with confidence that yes, it is good to have a patent shunt and try to go in for the biliopathy for a direct intervention in the form of a bilioenteric anastomosis, but also be aware that many a times, even with low pressure, there may not be actual decompression of these varices, and access to the biliary system may still be so difficult that one may not be able to do anything about it. And many a times I've just been able to do a cholecystectomy and not been able to tackle the biliary obstruction at all. And I would love to hear about Dr. Sahni's experience with this. Like going in for biliopathy after having a patent shunt and then trying to access the biliary system.
So I agree with you totally. Even if you've done a shunt and it's patent, you could still find it very difficult to access the bile duct. The thing that I was, and you have to abandon the procedure. And what we keep in mind is that when we are close to 8 units of transfusion intraoperatively, we say, okay, now we must start thinking of abandoning the procedure. This is just an arbitrary figure. It's you know, we don't have as many numbers to say, okay, if you use 12 units, then it's fine. If you use 8 units, it's fine. If you use 15 units, that's a problem. We've just taken an arbitrary figure of 10, because by the time you actually get control of the bleeding and get everything else done and sorted, the patient has actually received 10 plus units of transfusion. And I don't think it's a great idea to have massive transfusions in these patients. And they tend to develop problems in the post-operative period. The thing that I had forgotten or I couldn't recall to mention to you was that there's some evidence, not very conclusive evidence, but there's some evidence that patients who've undergone multiple sessions of endoscopic therapy, previously used to think it was only sclerotherapy, now we believe it's both sclerotherapy or varicose ligation. This itself could predispose people to the development of portal biliopathy. So in a case control series, we felt that the numbers were a little higher in the group which had received endoscopic therapy compared to those who had not received endoscopic therapy. The numbers are not good enough for us to you know, at the moment say that this is definitive evidence. I'm sure if there was definitive evidence, a lot of people would give up doing endoscopic therapy and would prefer in high-risk varices, especially in patients with EHPVO, to go ahead and do prophylactic shunts. But I don't think the evidence is that strong. What we do encounter in patients who have undergone variceal ligation or sclerotherapy is a greater technical difficulty in shunts. Doing shunts. This is again not something that can be documented, in the sense that how do you document that a procedure was more difficult to do? Do you document it just because a patient received more transfusion? Not true, again, because more transfusions could actually mean that you lost blood by doing the anastomosis because your clamp slipped or a suture cut through. So there are multiple reasons for more transfusion. So these are difficult to do, document with a certain degree of certainty, but definitely people who've operated on these patients for a long period of time would tend to agree that these are areas where we all tend to be a little wary, a little more cautious, a little more mentally prepared to encounter more difficulty.
All right, Peush has a couple of points that I think I need to go over with you again. This thing about doing sclerotherapy or banding resulting in a greater incidence of portal, what you're calling biliopathy, and I'll come back to that term in a moment. Well, I think a very formal, systematic, database, systematic analysis needs to be done before views like this are expressed or articulated. Because it's as likely that by doing repeated sclerotherapy, banding, you're keeping more people alive for a longer time, which is then allowing them to progress and the entity of portal cavernoma cholangiopathy to emerge. If you look at the number who are receiving sclerotherapy and what proportion of them are actually developing portal cavernoma cholangiopathy, you would find that there are many more patients who have been sclerosed, obliterated, followed up for 10 years or so more, who have not developed cholangiopathy. So I think I am
not for a moment saying
to be
that
looked at more systematically
that we
before
have.
we articulate it before this audience. That was one point. The
No,
other
so
thing was,
it's an impression. It's an impression, and it's an impression that I
which needs to
shared.
be validated
I
by
said very clearly
systematic
that I
data
don't think there's
analysis.
evidence for it.
Yes, indeed. Now, the other thing was, I think both of you were talking about an effective shunt done, patent, portal system decompressed, portal pressures down, but the vessels have not disappeared from around and outside the bile duct. So biliary obstruction is difficult to manage. Well, I think at Lucknow, at least, and I personally have good experience of managing these people endoscopically. And with a patent shunt, the risk of hemobilia due to intracholedochal collaterals is pretty small. I think overall, I would say my personal experience is about managing about 48 to 50 such patients over about 150 to 200 endoscopy sessions. And our rate of hemobilia in these was higher in those who were not shunted or had no shuntable vein anatomy than in those in whom a patent shunt was present, where it was negligible. Major hemobilia requiring transfusions or abandoning the procedure was not seen. And endotherapy for strictures, for stones, using conventional techniques of mechanical lithotripsy, balloon extraction, or stent bundles to dilate strictures were very successful. So I think in this situation, I think once you have an effective shunt in place, you could think of giving your endoscopist a chance to tackling the biliary obstruction rather than making sure that it's only surgical treatment is offered. And finally, regarding your impression about NCPF and cirrhosis being equally responsible for the entity of portal cavernoma cholangiopathy, well, if you go back and look at it, we looked at these data very carefully when this consensus was articulated. And what we had was old data of 90s, 80s, even earlier data suggesting that cirrhosis results in portal cavernoma cholangiopathy. Now there they have differentiated between extrahepatic and intrahepatic changes. Intrahepatic portal venous changes could well be a part of cirrhosis, while up to 20 to 30% of people with cirrhosis are known to develop EHPVO. When you have a portal vein block and a cavernoma develops, then yes, the patient does have cirrhosis and changes of portal cavernoma cholangiopathy, but a portal vein is thrombosed and an extrahepatic cavernoma is possibly due to that rather than cirrhosis. And I think the numbers and data for NCPF proving that they are responsible for the entity of portal cavernoma cholangiopathy are very small, and the imaging is very, 30, 40 years old. With current conventional images, a good series of NCPF clearly having this entity of portal cavernoma cholangiopathy. In the absence of an extrahepatic cavernoma, I don't think we have good evidence for that. So we thought we'd stick to portal cavernoma cholangiopathy, leaving these entities which till they are better characterized and supported by modern imaging to include them under the ambit of the entity. Those are the points I'd like to make.
So I think we have only 10 more minutes left. So any questions from audience? Otherwise, I will ask one question to the, Dr. Chaube wants to ask something.
Morning, sir. Sir, what's your take on the incidence of non-serotic portal hypertension, which includes EHPVO and CPF? We weren't including HBOT. So what's your take on the incidence? In my experience, I saw that till till 2003, we in armed forces we were doing almost 15 to 18 shunts a year, and then it almost came for last 8 years. Thereafter, I was in clinical practice. I hardly saw a shunt being done for EHPVO or NCPF. What's yours, sir? And in my personal communication with the department at AIIMS, I was told the number of shunts have got, like when I was there, sir, in the department, the department was doing almost 80 shunts a year, and that it has reduced to almost half. So what's your take on the incidence, true incidence?
So I'll again say something which Dr. Saraswat will want to counter. The belief amongst gastroenterologists is that NCPF has disappeared or is almost negligible now. I think if one doesn't systematically make an attempt to exclude that diagnosis, a lot of these patients would become good child's age cirrhosis. and will receive endotherapy and will remain well for a long period of time, because essentially they have good liver function, so they'll remain well. And there's no reason for people to go looking for the primary etiology of the condition, and therefore the numbers will automatically fall down. The numbers are low in our center also as far as NCPF is concerned. For long periods of time, we don't see a patient with NCPF. Now, as far as surgery for extrahepatic portal venous obstruction is concerned, patients get referred to you. Very few patients come to you on their own. And till my last visit to the FMC in Pune, every time I went there, I was asked by the surgeon to request the physicians to please refer patients with extrahepatic portal venous obstruction, which they continue to treat endoscopically. Now, Dr. Saraswat will say, we give you an equivalent results, so why should we offer the patient ask the patient to undergo surgery? Sure, good enough. So I don't think that the numbers have disappeared. Extrahepatic portal venous obstruction is still there. It's just that there are a lot more people who can perform eradication of those varices efficiently with smaller or fewer complications. And therefore, the numbers of patients who are coming to surgeons has decreased. Now, has the actual incidence decreased? I don't think there's data to say one way or the other that the incidence has remained the same or it has actually decreased. The problem is going to be we have very little data which can tell us what the incidence was 20 years ago. So comparing with now, the only numbers that we are looking at is the number of people undergoing surgery in a hospital where those numbers were being achieved, where a certain number was being achieved previously, and now half the number or a third of that number is being achieved now. During the pandemic, because of the limited number of operation theaters open at various points in time, first wave, second wave, various lockdowns and unlockdowns, at our center, for one full year, we didn't do a shunt at all. But that doesn't mean our waiting list has gone down. We still have a 2.5 year, 3 year, 2 year waiting list available. In the limited availability of operating time, obviously the endoscopic modality for therapy would be used more because that was an option that was available all the time. And therefore that option tended to be used more. Of course, there too, there was a decrease in numbers, patients were not coming to the outpatients and so on and so forth. But the number of patients is very difficult to say that the actual numbers have gone down. All that you have is hospital data. I used to treat 25 patients. Now I treat only 12 patients. That's the only evidence that you have, which we all know is subject to a lot of bias and therefore would definitely not give us the right picture. My personal impression is that extrahepatic portal venous obstruction is more or less the same. NCPF may be on the downward trend, but I don't know as yet.
Last question, which again students find it difficult to answer. Once we have done a shunt, is it necessary to demonstrate the patency? If yes, how do you do it? And if it shows a block, what to do?
So again, my view is that we really don't need to do much follow-up. If at all we need to do a follow-up is an endoscopy 3 to 6 months later. And if there is a decrease in varicose grade, prove that this is proof enough that there is the shunt is not blocked. We know that shunts continue to get blocked in the first 2 years, but the maximum amount of blocks tend to happen in the first 6 months. So if you wish to look for shunt patency, look for it at the end of 6 months. If you wish to look for it again, then you look for it at the end of 2 years, and then you stop. Now, endoscopy is one option. If you don't have endoscopy, but you have ultrasound, that's the other option. The problem with ultrasound is sometimes becomes very difficult to find the site of anastomosis. All that you can find is some flow within the splenic vein, moving towards the renal vein, and you don't see the actual anastomosis per se. So that's why the indirect method tends to be a little more sure of, your likelihood of picking it up is a little more. Doing a CT portography to do this, I'm not sure is worthwhile. That would be a more definitive answer. Again, not 100%, but a more definitive answer as far as shunt block is concerned. Now, if you find a shunt that's blocked at 6 months or at the end of 2 years, then essentially the patient needs to go back to the endoscopist. If the patient has a patent superior mesenteric vein as young, below 30 years of age, then we would suggest that we could do a mesocaval shunt. A lot of patients don't want to have a second surgery done and would not want it done. And therefore, most of these patients would tend to go back to endotherapy.
Anu, any different approach than what Dr. Peush said?
Sir, I think the concept behind is the same for us also. I mean, the demonstration of shunt patency ultimately becomes important on the presentation of the patient. If the patient is asymptomatic, but if the patient bleeds or if the patient has PCC, so I would say that if the shunt is thrombosed, then the original indication for surgery will also determine as to how far you are going to go for looking at other veins for decompression. For example, if the original indication was bleeding, right now, even with a blocked shunt, the patient doesn't have varices, we need not do much about it. But if the patient has redeveloped varices, then of course, one would like to first go for endoscopy as always, and also like to see whether there is another vein which is available for a shunt. We have been following our patients with the ultrasound Dopplers, and especially more so for the first 2 years. And again, I think that is what makes Dr. Peush say that we don't really go, because we haven't had much interventions for blocked shunts. So if we are not going to do anything about the blocked shunts, then what are we doing with following them up for demonstrating their patency? But with patients with PCC, patients with varices not controlled on endoscopy, and a blocked shunt, yes, then one really needs to look at whether there is another vein which is available, which one would like to use for a shunt. I haven't had any experience with this, like I haven't had to intervene in a patient who has a good shunt.
One line answers from both of you about anticoagulation in the immediate perioperative period and long term.
We do, sir. We like actually when we started, I think the protocol which we took was one of Henry Bismuth's earlier papers. So we give heparin for 7 days, and because our results were good, we didn't want to change it. So I know that Dr. Peush's group doesn't use except for the single injection at the time of surgery, but we haven't changed. So we continue to use for a week, and we do a Doppler at day 7, and after that we discontinue. Of late, we have been using aspirin 75 milligrams once a day for long-term this thing. And again, I don't really have any control like group to say, but since our results with this are good, we are continuing to stick with it. We started like that, and we are continuing to do that.
Dr. Peush?
We don't use post-operative anticoagulation in any form, or even an antiplatelet agent. And we have a 20% documented shunt block rate and about a 10% rebleed rate, under 10% at the moment, rebleed rate. So only about half the patients with the blocked shunt will actually rebleed. This is long-term follow-up, over 10 years plus of follow-up.
So what is your experience? We feel a lot of these patients develop thrombocytosis post-splenectomy, and like platelets really go very high. So actually, I am kind of okay with using the aspirin, baby aspirin, which we have been using. We continue to use.
Dr. Chaube wants to ask.
It's Professor Saraswat, sir, one question. If I remember, sir, in 2001 or 2000, there was almost a consensus conference about the primary mode of treatment for EHPVO, because one of the main factor was that besides the bleeding, patient used to have growth retardation, and it was seen that post-shunt they, the growth was restored and there was a concept primarily of who come with the bleeding and that episode has been taken care of. They should be primarily by surgeons doing shunt, and the rest of the patients can be managed. So, what is the present status of these EHPVO patients?
Yeah. See, one is the scientific recommendation, the other is the practical reality.
Yeah.
The number of surgeries being done in any large centers in any state is minuscule compared to the numbers of patients who are needing shunts and the numbers who are undergoing endoscopic management. So I personally also believe that the treatment for portal hypertension is correction of portal hypertension, which is best done by a surgical shunt. And that is probably going to be the best way for long-term prevention of complications like PCC and others. However, the practical reality is that while waiting for shunts and centers, not happen. But I think it is recommended, it is told to patients, and I think that would be the correct approach, provided the patient agrees to undergo the procedure once the primary indication, that is bleeding, has been taken care of. The second question about growth retardation, there were good data from both SGPGI, Dr. Ish Bhatia had published an excellent paper around that time, and Professor Sareen's group from that EHPVO were poorly identified, and post-shunt improvement and restoration did happen. Bleeding stopped, also growth improvement did happen. That being a reason for doing surgery and not doing endoscopic therapy was eventually a very strong recommendation. With DOACs now being available and other drugs, they're easy to monitor.
So we have lost you, can't hear or see.
The question to me was what kind of approach of doing short-term anticoagulation, not just 1 week as Anu has said, but for a few months or maybe up to 6 months, and once you are patent, then take off the anticoagulation and leave the patient with a patent shunt. For the individual patient, that shunt is very valuable. Number one. Number two, I think endoscopic observation of variceal grading is unsatisfactory, because even after a patent shunt, widely open, you still find grade 2 varices persist in these people. The red color sign goes away. Probably the portal pressure is down. But looking at presence of varices or size of varices is a very insensitive way to assess shunt patency. Finally, for the Doppler is useful, but Doppler, I think, unless you look at the shunt flow velocity and 80 to 100 centimeters per second, a normal portal vein velocity, tells you, yes, it's a nicely flowing shunt. You just see some flow and it is 8, 10, 20 centimeters, probably a partially or if not a completely blocked shunt. So I think those issues would be the thoughts I've had to mention. Thank you.
So may I make a comment about growth retardation? Just one small comment, that I don't think the last word on growth retardation has been said. That because the number of patients who have had just splenectomy and DVAS for any reason, like loss of splenic vein or non-availability of splenic vein, we find that these children also show a very good growth spurt. Like many patients who have not had a shunt also, just because a huge swelling in splenectomy alone also, or splenectomy and DVAS alone, they also show a growth spurt. Like maybe they are growing children, and once we take away this huge spleen, which has been causing, pain, interfering with their intake,
Recurrent
causing
bleeds.
causes postprandial, and bleeds, So they also show a growth spurt. So I'm not very clear
Yes,
whether
it's
it is
not
the
a
shunt
one-to-one
versus-
equation. Can't equate total hypertension
Yes.
and growth
Yes.
retardation.
Yes.
Okay, thank you, Dr. Piyush, Dr. Anu, and Dr. Saraswat. I think we close the session. I will just like to make one comment that I'm not very happy with the involvement of the students. I expect more. So please, this session is for you. I want your participation more than the faculty's participation. So Dr. Anand has made a schedule. Please follow it. If you can't do it next week, please let him know in advance, and so that we can make an alternative arrangement. But I don't want any last minute dropouts, and these sessions should have more active participation from students, both in terms of attendance and in terms of active participation. I know some of you have said that 9 to 10 is not a suitable time. We are very seriously considering changing it to 8 to 9, and I hope that attendance will improve. But more than the attendance, even 20 people who are present today, I didn't see any active participation except Lokesh. So that is not the purpose of this tutorial. The purpose of this tutorial is more active participation from students. So please be proactive. Okay. Thank you, everybody. Thank you. We will close
Thank you, sir. Thank you.
Thank you.